Imagine you wake up one morning, right, and you have this just awful stiff neck.
Oh, yeah, the absolute worst way to wake up.
Right, and a pounding headache to go with it. So you do what anyone would do. You go to the doctor.
Naturally.
You sit on that, that crinkly paper on the exam table.
I can literally hear that sound right now.
Yeah, and a doctor comes in, asks you a few questions, shines a light in your eyes, maybe asks you to touch your chin to your chest.
Which seems pretty straightforward to the patient.
Exactly. To you, it feels like they're just running through a really simple mental checklist, like a basic binary, right? Broken or not broken, sick or healthy.
But behind their eyes, it's a completely different story.
It's wildly different. They're fighting this invisible, high-stakes battle against statistical probabilities, biological gray areas, and even their own cognitive biases.
It's basically an invisible pinball machine in their head.
It really is. Welcome to our deep dive today. We're looking at a pretty dense medical text on clinical decision-making. But our mission here is to translate all these visual blueprints, these complex flow charts and diagrams from the text, into a theater of the mind for you, the listener.
Because what's fascinating here is that medical decision-making isn't just about memorizing an endless encyclopedia of symptoms.
Right. Nobody's brain works like that.
Exactly. The human brain just cannot compute that way. Instead, it relies on these invisible flowcharts, probability nomograms, and statistical curves to make sense of the chaos.
Okay, let's unpack this. Because to figure out what is wrong with you, a doctor first has to mathematically define what is normal. And that brings us to our first visual, the classic bell curve.
Right. We all know the standard bell curve shape. But in medicine, relying on that symmetrical curve creates a massive statistical trap.
Because of how we draw the lines, right? I mean, we take a healthy population, run a blood test, plot the results, and then by strict mathematical convention, we just arbitrarily decide that the middle 95% is normal.
Which is just a line in the sand, really.
Yeah, which means you are automatically slicing off the extreme 2.5% at the top and the 2.5% at the bottom, and we label them abnormal.
Exactly. And this raises an important question. Does an abnormal result actually mean you have a disease?
I'm guessing no.
Not at all. Being in that bottom 2.5% often just means you are statistically outside the arbitrary cutoff.
Okay, give me an example of that.
Sure, take a young, healthy woman who happens to have a lower ferritin level, the iron in her blood. Her result falls into that abnormal tail on the graph.
Right.
But she isn't suffering from a life-threatening illness. It is just the statistical reality of her physiology at that exact moment.
So it's literally like grading on a curve in a highly competitive school.
That's a great way to put it.
Like, even if the entire class is full of absolute geniuses, somebody still has to be in the bottom 2.5%. They still technically fail the test, even if they're brilliant. But wait, doesn't that guarantee that perfectly healthy people will constantly get flagged as sick by their doctors?
It guarantees exactly that. If a doctor runs 20 different blood tests on you, mathematically, there is a very high probability that at least one of those results will come back abnormal simply by chance.
Wow.
Yeah, and it gets even messier when you realize that the bell curve for a healthy population and the bell curve for a diseased population usually overlap.
Oh, so there's like a muddy gray area in the middle?
Exactly. A specific test result could belong to a totally healthy person at the high end of their curve or a genuinely sick person at the low end of theirs.
Which means a test result isn't a definitive answer at all. It's just a probability.
Precisely.
So if the bell curve is muddying the waters right out of the gate, doctors need a way to weigh how much a symptom or a test actually matters. They need like a sort of thermometer of truth, right?
A thermometer of truth, I like that.
Yeah, a way to see if a symptom turns up the heat on a diagnosis. Which brings us to the next diagram in the text.
Right, in diagnostic math, that thermometer is called a likelihood ratio.
Okay, break that down for us.
Imagine a vertical thermometer where the baseline, right in the middle, is the number 1. If a symptom has a likelihood ratio greater than 1, the mercury rises. It turns up the heat on the probability of a disease.
Okay, makes sense. And if it's less than 1?
Then the mercury drops, cooling the diagnosis down.
Let's bring this back to that stiff neck scenario from the beginning. If I come in with a stiff neck and a terrible headache, the historical medical teaching says, look out for meningitis.
Right, that's the classic fear.
There is even that classic physical test, Koenig sign, where the doctor stretches your leg to see if your neck hurts. I always assume that if a doctor does that test and it hurts, boom, meningitis confirmed.
It is an absolute hallmark in medical education. But here is the reality check from the text. When you actually look at the prospective data, The likelihood ratio for neck stiffness and Kernig sign is essentially 1.
Wait, really? 1? Meaning the mercury doesn't move at all?
It barely moves the needle.
Yeah.
Finding that symptom carries almost 0 diagnostic weight.
But why? I mean, it's literally written in the textbooks as the classic sign of meningitis. How can it be mathematically useless? Is it just because neck stiffness is incredibly common? Like I slept funny on a terrible pillow, so my neck hurts.
Well, that's definitely part of it. The background noise of everyday aches and pains is high, but it's also about the biology and the timing of the disease.
What do you mean by timing?
Severe meningeal irritation signs, like Kernig's, often appear quite late in the disease progression.
Oh, I see.
So if a doctor waits to see that classic sign before making a diagnosis, they've waited too long.
The damage is already done.
Exactly. Furthermore, testing for it is highly subjective. I mean, how much resistance is just tight hamstrings versus an infected nervous system?
Yeah, that's a good point.
When you combine common background symptoms, late-stage presentation, and subjective testing, the mathematical value of that symptom drops right back to baseline.
That is wild. So if an individual symptom can be that flimsy, how do doctors evaluate the actual tests they order? Like the ECGs or lab scans? Because those have to be more reliable, right?
They are more reliable, but they come with a brutal biological trade-off. And this is visualized as an arching graph called the ROC curve.
The receiver operating characteristic curve.
Yes. Picture a graph. On the vertical axis, going up, you have sensitivity. That is the test's ability to catch true positives. If the disease is there, the test finds it.
Okay, got it.
On the horizontal axis, moving left, you have specificity. That is the test's ability to avoid false alarms, ruling out the disease in perfectly healthy people.
So the dream scenario would be a test that shoots straight up and curves sharply into the top left corner. 100% sensitive, 100% specific.
That would be the holy grail. It catches every sick person and never scares a healthy person.
But I'm guessing that doesn't exist.
No, the reality of human biology means perfect tests don't exist. Most tests force a compromise. The curve bows out gently.
So you have to choose.
Exactly. Do you want to catch every sick person but terrify a bunch of healthy people with false alarms? Or do you want to avoid false alarms but risk missing some genuinely sick patients?
And you see this terrifying trade-off in cardiology all the time, right? Especially with ECGs, the electrocardiograms checking for heart attacks.
Yes, the text uses a great example there.
They look for something called ST depression, which is just a tiny dip on the electrical readout. If the doctor sets the warning threshold at a tiny 0.5 millimeters, that test is highly sensitive. It will catch almost every single blocked artery.
But the biology is messy.
Right, because anxiety, hyperventilation, or just a weird resting heart rate can also cause a 0.5 millimeter dip.
Exactly. So if you use that low threshold, you get massive false alarms.
But if they move the threshold up to 2.0 millimeters, it becomes highly specific.
Yeah.
Very few false alarms. The problem is, at 2 millimeters, you are missing people who are in the early stages of a very real heart attack. And here's where it gets really interesting, though. If I am the patient sitting in the ER with chest pain, I want 100% sensitivity.
Of course you do.
I don't care about the false alarms. Just do not miss my heart attack. Send me to the catheter lab, run all the tests. But why can't doctors just do that for everyone?
Well, if we connect this to the bigger picture, doing that for everyone would cause the entire medical system to collapse. And worse, it would actually harm patients.
Because of the risks of the procedures.
Yes. This introduces a critical concept called the treatment threshold. Every medical intervention carries risk. An angiogram involves threading a catheter into your heart. That can cause a stroke.
Oh, wow. Yeah, you don't want to do that unless you have to.
So doctors have to weigh the penalty of missing a disease against the risks of the investigation or the treatment itself.
It's a massive balancing act.
Precisely. If we suspect a pulmonary embolism, a blood clot in the lung, the penalty for missing it is sudden death. Therefore, the threshold for starting treatment, like giving you blood thinners, is lower.
Because waiting for certainty is just too dangerous.
Right. But if the treatment is highly toxic, like starting intensive chemotherapy for a suspected brain tumor, the threshold is incredibly high. You need absolute tissue biopsy certainty before you inflict that level of harm on a human body.
Okay, so the doctor is balancing the bell curves. They are writing the thermometer of likelihood ratios. They are plotting those ROC curve trade-offs.
It's a lot of mental math.
It is. But even the absolute best test on that graph is completely useless if you apply it to the wrong person. And this brings us to what I think is the most mind-bending diagnostic trap of all.
Oh, the Fagan nomogram.
Yes, it involves this visual tool called the Fagan nomogram and a mathematical puzzle known as the Harvard problem.
This is where human intuition utterly fails against the cold reality of statistics. The Fagan nomogram is a tool that calculates pre-test probability. It mathematically proves that the meaning of a positive test result changes entirely depending on what you believed before you ran the test.
Okay, let's do the Harvard problem, because I want to see if you, the listener, fall into the same trap that literal medical experts did.
This is a classic one.
Here is the scenario. There is a disease that affects 1 in every 1,000 people. So it's fairly rare. We have a diagnostic test for it, and this test has a 5% false positive rate.
Meaning, out of 100 perfectly healthy people, 5 will accidentally test positive.
Got it. 1 in 1,000 have it, 5% false positive. Now, a person walks into the clinic off the street, takes the test, and tests positive. What are the chances they actually have the disease?
And when researchers posed this exact scenario to a group of doctors at Harvard Medical School, almost half of them jumped to the most intuitive answer. They guessed 95%.
Because they heard 5% false positive, and their brains simply flipped it to 95% accurate.
Exactly. It feels intuitively correct.
Right. It feels so obvious. But they were completely, wildly wrong.
Let me actually try to work this out the way a doctor should. Okay, we have a population of 1,000 people.
Okay.
We know the disease prevalence is 1 in 1,000. So out of that whole group, exactly one person actually has the disease.
Correct. The test will catch that one person. That is your one true positive.
Okay, but what about the other 999 healthy people? Well, the test has a 5% false positive rate. What is 5% of roughly 1,000 people? It's 50.
Yep. 50 false alarms.
Oh, wow. So the test is going to accidentally flag 50 perfectly healthy people as positive.
You nailed it.
So in that room, I have 51 total positive results in my hand, but only one of them is the real deal. 1 out of 51, that's, yeah, about 2%?
2%. A positive result on a seemingly highly accurate test. And you only had a 2% chance of actually being sick.
That is blowing my mind.
The false positives completely drown out the true positives because the disease is so rare to begin with. You know, it's like using a metal detector. If you are walking on a beach in the Caribbean where a famous Spanish galleon sank and your metal detector beeps, there is a very high probability you just found gold.
Because the pretest probability is high, gold is everywhere under the sand.
Right. But if you take that exact same metal detector with the exact same beep and walk through a municipal junkyard, a beep just means you found a rusty tin can.
I love that. The beep hasn't changed.
The sensitivity of the machine hasn't changed at all. But the beach you were walking on, the pretest probability, changes the meaning of the beep entirely.
That is a brilliant analogy. And in clinical practice, this is an ironclad rule. A clinician must anchor their estimate of probability on the prevalence of the disease in that specific population before they even order a diagnostic test.
So context is everything.
Absolutely. If you take a 20-year-old with 0 risk factors and run a complex cardiac stress test, a positive result is almost certainly a false alarm.
The junkyard beep.
Exactly. You are testing a low-risk population for a rare disease.
But this is where the friction happens, right? We've mapped out all this beautiful math. But doctors are not calculators. They are human beings.
Highly stressed human beings.
Right. They get tired, they get hungry, they take mental shortcuts. And that leads to understanding how human thought actually processes all this data through what cognitive psychology calls the dual process theory.
Yes, if we look at the cognitive flowcharts of human thought from the text, our decision-making splits into 2 distinct paths. Type 1 thinking and type 2 thinking.
So what's the difference?
Well, type 1 is fast, intuitive, and heuristic. It's automatic pattern recognition. It operates subconsciously. Type 2 is the exact opposite. It is slow, analytical, deliberate, and effortful.
And evolutionary biology dictates that we spend about 95% of our daily lives locked in type 1 thinking. Right?
Oh, absolutely. Driving a car on a familiar route, reading a facial expression, catching a falling glass.
It's incredibly energy efficient. It's how we survive without burning out our brain's glucose supply by overanalyzing every leaf blowing in the wind. But I imagine it is incredibly vulnerable to error when applied to complex math.
To demonstrate how aggressively our type 1 intuition wants to take over, consider a classic cognitive puzzle from the literature, the bat and ball problem.
Oh, I've heard of this. Let me try this live. Give me.
Okay, a bat and a ball together cost £1 and 10 pence. The bat costs exactly 1 pound more than the ball. How much does the ball cost?
Okay, my intuition, my type 1 brain immediately screams 10 pence. It just feels right. 1 pound plus 10 pence is 110. Done.
But force yourself into the type 2 flowchart. Do the actual math.
Right, okay, slow down. If the ball costs 10 pence and the bat costs a pound more than the ball, then the bat would be 1 pound 10. Together, that makes 1 pound 20.
Right.
Wait, so the ball has to be 5 pence. If the ball is 5 pence, the bat is 1 pound and 5 pence. Together, 1 pound 10.
Wow. It proves that our brains are literally wired to jump to intuitive conclusions that are mathematically impossible.
And in medicine, these intuition jumps are called cognitive biases, right?
Exactly. They act like glitches in the diagnostic flowchart, irrational overrides that derail a doctor's thinking.
Like ascertainment bias,
Yeah.
where you see exactly what you expect to see.
Give us an example.
Well, imagine an emergency room at 2 in the morning. A patient is wheeled in. They're a frequent flyer who comes in every few weeks for self-harm and overdoses.
Okay.
Tonight, they are drowsy, slurring their words, unresponsive. The doctor looks at the chart, sees the history, and their type 1 pattern recognition brain immediately says, oh, it's just another overdose.
Which is an incredibly efficient use of mental energy, but deadly if it's wrong.
Right, because they assumed the pattern held. They didn't look closely enough at the pupils or feel the back of the head. They completely missed the fact that the patient slipped on the ice and actually has a traumatic brain injury.
And then there is diagnostic momentum, which I find fascinating.
Oh, how does that one work?
Well, once a patient is given a label, say, a triage nurse writes down probable pulled muscle for back pain, that label gathers momentum. Everyone down the line anchors to it.
Oh, so the next doctor just assumes it's true.
Exactly. The junior doctor reads it, the attending physician reads it, and they all subconsciously stop looking for alternative answers, like a kidney infection or a spinal abscess.
And we can't just blame the doctors for this. I mean, put yourself in that ER at 3 a.m. Alarms are blaring. The waiting room is full. The doctor hasn't slept in 16 hours.
The environment plays a huge role.
The environment itself, the time pressure, the cognitive load, physically forces the brain to conserve energy. It traps the doctor in that fast, intuitive, error-prone type 1 pathway.
You desperately want your doctor in slow, analytical type 2 mode, but the room is screaming at them to just use pattern recognition and move to the next bed.
So how do we fix this? How does a doctor fight back against their own biology?
They have to use cognitive debiasing strategies. Think of these as intentional speed bumps installed into the workflow to force the brain out of type 1 and into type 2.
So forcing the brain to do the math on the bat and the ball.
Exactly. One widely used strategy from the text is the formalized checklist, like the ABCDE approach in trauma. Airway, breathing, circulation, disability, exposure.
Oh, I've seen them do that on medical shows.
Yeah. You might look at a bleeding leg and immediately want to fix it. That's type 1 focus. But the checklist physically prevents you from jumping ahead. You must evaluate the airway first, then the breathing. It forces methodical analysis.
And communication protocols do the same thing, right? Like the SBAR system for handing over a patient. Situation, background, assessment, recommendation.
SBIR is brilliant because it dismantles diagnostic momentum. Instead of a nurse just handing over a patient and saying, I've got a pulled muscle for you in bed 4, they are forced to present the raw, objective data before they give their assessment.
So it removes the anchor.
It allows the receiving doctor to evaluate the raw facts without being pre-anchored to an intuitive guess.
Okay, so let's fast forward. The doctor has navigated the overlapping bell curves, they've figured out the likelihood ratios, they've survived the Fagan nomogram and didn't fall for the junkyard beep.
They've run the gauntlet.
They've used their SBAR checklist to fight off their own brain glitches. Now they have to walk back into the exam room, sit down on that stool, and talk to the patient. How on earth do you communicate all of this invisible math to someone who is terrified and just wants to know if they are going to be okay?
This is perhaps the hardest step of all. Clinical communication. The research strongly warns against using vague words like common or rare when describing the risks of a disease or a surgery.
Why is that?
Words leave too much room for subjective interpretation and bias.
Right, because rare to a surgeon who does 1,000 hernia operations a year means something entirely different than rare to me, the patient who has never had surgery in my life. If you tell me there is a rare chance of death, my brain doesn't hear statistics. My brain just hears the word death.
Precisely. We fall victim to the framing effect. If a doctor says you have a 99% survival rate, the patient feels great. If the doctor says 1 in 100 people die from this, the patient is terrified.
But it's the exact same statistic.
It is the exact same statistic, framed differently. So, to cut through this psychological noise, modern diagnostic communication relies on a powerful visual tool, the 100 faces grid.
I love this concept from the source text. Instead of just rattling off raw percentages that our primate brains struggle to contextualize, the doctor actually hands the patient a piece of paper with a visual grid of 100 simple, stylized faces.
It immediately anchors the abstract math into physical reality. Let's say we are discussing a specific surgery. You look at the grid. 90 of those faces are colored yellow and smiling red. Those are the people whose symptoms completely resolve.
Okay.
8 faces are green and neutral. The surgery happens, but their pain doesn't change. One single face is highlighted orange, representing a severe complication like a stroke. And one single face is colored gray, representing mortality.
It's so profound. By making it visual, it completely cuts out the doctor's communication bias, and it prevents the patient's panic response from blowing a 1% risk out of proportion.
It creates a shared reality in the room. The complex ROC curves, the statistical tails of the bell curve, the probabilistic thresholds, all of that invisible math is finally brought back down to a tangible human scale. The doctor and the patient are looking at the exact same data, understanding the exact same risk.
So what does this all mean? It means that clinical decision-making isn't a straight, clean line from symptom to cure. It is not just looking at an X-ray and pointing to a broken bone.
Not at all.
It is a massive, multidimensional pinball machine. A doctor's mind is constantly bouncing between biological realities, population prevalence, cognitive traps, and environmental pressures, all before they even say hello. It's truly a masterclass in human cognition.
It is a remarkable balancing act. It merges the art of human intuition with the cold, hard rigor of statistical science, all while actively fighting against the brain's natural desire to take the easy way out.
Well, thank you for coming on this audio tour of medical flowcharts and diagnostic math with us. We promise to turn those invisible blueprints into a theater of the mind, and hopefully you're seeing the doctor's office in a whole new light.
And I want to leave you with a final thought to mull over. The next time you visit a doctor and they order a test, whether it's a routine blood draw or a complex scan, think about the Fagan nomogram.
The metal detector on the beach.
Exactly. Ask yourself, and perhaps ask your doctor, what is the pre-test probability here? Are we ordering this test to prove I have a disease, or are we mathematically just trying to rule it out in a low-risk scenario?
Understanding that one single hidden piece of data might completely change how you interpret your own health results. It helps you distinguish the real gold from the rusty tin cans. So the next time you walk in with a stiff neck, remember the X-ray machine might be straightforward, but the mind reading it is navigating a labyrinth. Catch you next time.